Now, I would like to invite Dr. Ranju Kharel as a speaking delegate. Dr. Ranju Kharel have completed her uveitis fellowship from Shankar Netralaya, India, and she is an assistant professor and uveitis specialist and have International Uveitis Society group training from Italy. Hello, ma'am. Are you there? Ma'am, you can share your presentation. Over to you.
Okay, thank you, Mero Eye Foundation. Thank you, Kapil, and thank you, Monica, for your kind introduction. Thank you all for giving me this platform. Today, I'm going to talk on the role of choroidal thickness assessment in case of unilateral acute anterior uveitis. So I have no financial interest or relationship to disclose. Uveitis is my subspecialty, and among all the type of uveitis worldwide, acute anterior uveitis is the most commonest type. It holds true for Nepal, for our condition. It holds true for our country also. So 61.8% of total uveitic population, they mainly present with acute and they mainly present with anterior uveitis. And out of that, we will be today dealing with the acute form of anterior uveitis. The choroid, which is the most vascular tissue of the eye, plays a very important role in pathogenesis of all kinds of uveitic disorders. And this choroidal involvement are found mainly in the posterior and intermediate uveitis, but they are less documented in case of anterior uveitis. In 2008, the concept of visualization of choroid using OCT came into existence by Spade and his colleague. So the ETI mode of OCT was used, and now also it is being used for the enhanced visualization of the choroidal anatomy, which has enabled us for the qualitative as well as quantitative analysis of the choroid, and it has very high reliability and reproducibility. So we thought of a study where we plan to study whether there is involvement of choroid in case of acute anterior uveitis. We know that in acute anterior uveitis, it's basically the inflammation of the anterior chamber where there will be presence of cells and flare, and we don't speculate any involvement of the posterior segment in inflammation. But there are some studies which document that yes, structural changes do occur at the level of choroid, leading to altered choroidal thickness even in case of anterior uveitis. And we wanted to assess this change in the structural thickness structure of the choroid in form of the choroidal thickness in the uveitic eye of our population. So we had three aims. First aim was to compare the subfoveal choroidal thickness between the affected eye and the unaffected eye in case of unilateral acute anterior uveitis. The second was to measure what was the change in the subfoveal choroidal thickness before and after treatment in such uveitic eye. And finally, to correlate whether this change in subfoveal choroidal thickness is associated with or is correlated with visual acuity or not. So simply we identified only those cases which were newly diagnosed unilateral acute anterior uveitis. So our cases with the affected eye, right? Like in this photograph, the left eye included the case that was the affected eye, and the unaffected other eye was served as the control group. We measured the subfoveal choroidal thickness just below the macula, around 1 mm diameter at the time of presentation and 2 weeks after treatment. So this was done both for the case group and the control group. It was a 1-year study, and the machine used was Heidelberg ST OCT, where the EDI mode was used. And how was the measurement done? It was done with the help of an inbuilt caliper, where the distance from the hyperreflective line, which represented the outer border of RPE, to the inner edge of suprachoroidal space, that is the hyporeflective line. That distance was measured as the subfoveal choroidal thickness. It was measured in micron, that is again representing the distance between the hyperreflective line and the hyporeflective line. The hyporeflective line is the junction of RP and Brooks memory, and the hyporeflective line is the choroidal junction. We had total 61 patients. That means 122 eyes, out of which 61 eyes were the case group and the other 61 eyes were the control groups. Most of the patients were between 26 to 45 years of their life. These patients were mainly male. Yes, we know that anterior uveitis are more in common of male population. So 62.3% were the male population. And as we know, the common triad of acute anterior uveitis is pain, redness, and photophobia. So this was seen in our population group also. Many of the times we were not able to identify the cause of uveitis, but in our study population, we could identify cause in most of the patients, and only 36% of the population were labeled as idiopathic, where none of the etiology was identified. Second common to the idiopathic group were the actually B27 associated population. When we come to the measurement of the subfoveal choroidal thickness, it was before treatment. That means at the time of presentation, it was 304. Sorry. It was 304, and at the same time, the subfoveal choroidal thickness in the fellow eye was 251 micron. So this shows the mean subfoveal choroidal thickness at the time of presentation in the untreated eye, which was 304, but in the fellow eye it was 251, and using the PRT test, it was found that there was significant statistical difference between the two eyes, which is seen in the box plot diagram also. So when you look at this picture, this is the OCT picture of the same patient. The right eye was the affected eye, the left eye was the unaffected eye. The right eye had the choroidal thickness of 401 micron, and the left eye had 258 micron. And this eye, after treatment, the choroidal thickness reduced in the affected eye to 274 micron. This was again statistically significant using the PRT test. So when we see in the pictorial form, at the time of presentation in this patient, the choroidal thickness was 306 micron, but after two weeks of treatment, it reduced to 257 micron. When we compare the choroidal thickness of subfoveal choroidal thickness with the visual acuity, we found that the visual acuity of the eye in logMAR in the affected eye was 0.36. However, in the unaffected eye, I don't have the picture of that. But however, in the same affected eye, after treatment was better. That is 0.2. It was 0.2, and that was also statistically significant. Now, main portion comes the correlation of the visual acuity with that. The visual acuity was correlated with the subfoveal choroidal thickness. With the decrease in the choroidal thickness after treatment, the visual acuity also came to the near normal line. Yes, there have been many papers across the world which have demonstrated that the choroidal thickness is related with the anterior uveitis. They have also demonstrated the relation of the choroidal thickness with specific group of anterior uveitis like actually B27, but our was the first of its kind in the nebulous population, and we could publish this paper in ISO in the uveitis issues too. However, we had some limitation in our study. That was the follow-up duration of this patient was not as long as required. The sample size was only 61. There was lack. We couldn't document the macular thickness where we could have correlated the macular thickness with the subfoveal choroidal thickness in this population, and we had the inbuilt caliper, but we didn't have the automated measurement of the choroidal thickness in our machine. So it is one of the important limitation of our study. However, we conclude that acute anterior uveitis is associated with significant increase in subfoveal choroidal thickness, suggesting that choroid is also inflamed during the anterior segment inflammation. The decrease in choroidal thickness after treatment can be taken as an important prognostic factor, even in case of acute anterior uveitis. And yes, visual acuity is correlated with subfoveal choroidal thickness, suggesting that the ongoing inflammatory process at the choroidal level during the acute stage of uveitis, it normalizes with the treatment. Thereby, the final point is the subfoveal choroidal thickness in acute anterior uveitis can be used in monitoring the disease progression and the treatment outcome. It is not just the cells and the fields that we need to see in case of anterior uveitis. We can monitor the disease, we can monitor the prognosis, we can monitor the outcome, even based on the basis of the subfoveal choroidal thickness. I'd like to thank Dr. Sunil Thapa and Mr. Suresh Raj Sharma for helping me in this study. Thank you.
Thank you, ma'am. It was a lovely presentation. I hope all the participants had lot of information through this presentation.